Good afternoon, everyone, and welcome to this RCPCH webinar on Time to Think Kawasaki disease. Today's webinar will be delivered by Professor Robert Tullow, who is a consultant pediatric cardiologist at University Hospitals Bristol and the Bristol Heart Institute, and he is the professor in congenital cardiology and pulmonary hypertension at the University of Bristol. And Paul Brogan, who is the Professor of Vasculitis and Honorary Pediatric Rheumatologist at UCL Great Ormond Street Hospital, NHS Foundation Trust. This presentation will last for 35 to 40 minutes, following which we will have a Q&A session until we close the webinar at 1 p.m. If anybody would like to ask a question, we request you submit them through the Questions tab on the webinar software on their screens. We will take questions at the end of the presentation. You can ask repeated questions if you like, but please bear in mind we only have a limited amount of time to answer questions before the end of the webinar. If we do run out of time and your question has not been answered, we will be able to respond to your question via email. For those of us joining us today who have colleagues who weren't able to join us, the webinar will be recorded and will be made available on Compass, the RCPCH's learning management system, in about a week's time. And now, without further ado, I would like to hand over to Paul to start the presentation.
Well, thanks very much for that introduction and welcome everyone. I think I can say good afternoon now, just by seconds. We'll move to the first slide. Great. Okay. So the purpose of today is to really raise awareness of this disease that we call Kawasaki disease. I think this is one of the great mysteries in pediatrics, and I really hope folks work out the cause and how to treat it effectively, certainly before I retire. And you'll be hearing some of the research that's going on at the moment to try and crack this puzzle. It's the leading cause of acquired heart disease in the UK. No longer is it rheumatic fever in that context. And in fact, outcomes have really not improved in the UK and elsewhere in the world in the past 3 decades, with very similar coronary artery aneurysm rates as compared to a British Paediatric Surveillance Unit study performed in the early 90s. And we'll go through that as well. So by the end of this webinar, we will be able to understand some of the diagnostic considerations to deeply understand that it's not just a tick box exercise. You have to think about the diagnosis, and you will make the diagnosis more frequently as a result. Have some knowledge, however, of the limitations of the diagnostic criteria and the broad differential diagnosis, and really understand the speed with which you have to act for Kawasaki disease, because that can affect outcomes. And also understand some of the prevailing myths around this disease. For example, no point treating beyond 10 days, which is hopefully a myth that we'll be able to debunk today. So this entity is a systemic inflammatory process resulting in a medium vessel vasculitis with predisposition for affecting the coronary arteries. It happens all over the world. 15 years ago, they used to say in India, we don't see Kawasaki disease. It's because they were misdiagnosing it as scarlet fever. But now we know that Kawasaki disease does exist in India and elsewhere. It seems to be more common in males, more common in children of Black African descent, certainly in the UK. There's some seasonality, and Professor Tullow will be teaching us about that, how it relates in the UK over the winter and spring months, and occasional epidemics, particularly in relation to outbreaks occurring in Japan. This is a common disease in Japan, affecting 322 per 100,000 children under the age of 5, and also much more common in South Korea, but less so than in Japan. In the US, again, more common than in the UK, between 19 and 25 per 100,000, but significantly less common than in Japan. In Sweden, they have a rather similar epidemiology to the UK, with 5.5 per 100,000 children. And the most recent epidemiology from the British Paediatric Surveillance Unit, performed in 2013, was an incidence of 4.55 per 100,000 children. But it's important to note that depending on the methodology you use, you can get a completely different result. So the Thin study used GP records to explore hospital admissions and GP referrals for Kawasaki disease, and estimated the incidence to be 9.1 per 100,000, demonstrating that methodology can affect the result in relation to incidence. Overall, however, seems to be a fourfold increase in hospital admissions, and you might regard this as good news because people therefore are thinking more about Kawasaki disease. So what causes Kawasaki disease? I don't know, and no one knows. And it's really when you get diseases that are auto-inflammatory or autoimmune, you often hear people saying, well, it's a combination of genetic predisposition plus environment. The latest theory is that there is a vast area over rural China which is responsible for the emission of agricultural toxins into the atmosphere, which are carried by tropospheric winds across the Pacific, causing the trigger for Kawasaki disease and subsequently being diluted from east to west as this so-called toxin propagates across the world. And this sounds incredulous, but is a theory that has not gone away. And when you fly aeroplanes with filters into these tropospheric winds, you can find a number of particles, including fungal components that may or may not exert superantigenic influence to be an immunological trigger for Kawasaki disease. But the reality is we don't know for sure if this is true or not. Certainly there is a genetic predisposition borne out by the ethnic predisposition. Why is it more common in Japanese, for instance? And it's not a monogenetic disorder, but rather a complex disorder where there may be many tens, 20s, or even hundreds of polymorphisms in genes that regulate the innate immune response and also vascular biology. There's a few examples shown here: TGF, B2, SMAD3 polymorphisms in the Fc gamma receptor, and also one not mentioned here, an important T cell regulator called ITPKC. But none of these genetic variants in themselves fully defines the genetic predisposition to Kawasaki disease, and at the time of this webinar, genetic studies to try and understand this better are ongoing. So it's a combination of nature and nurture is the answer. But using that very simple model, you can begin to model an individual patient risk, but also the global distribution. So considering genetic contribution, increase in males with a family history sometimes, and other genetic polymorphisms, as I've mentioned to you, in children who generally live in a rather clean environment. So this is the hygiene hypothesis. But then 7 to 21 days prior to the diagnosis, there may be exposure to an infectious agent or a wind-borne toxin, and bang, you can then develop a perfect storm for Kawasaki disease. And if you use that model, it may not only just apply to individuals. So this is some work that came from the University of Toronto, and using this modeling, they say that they can account for 80% of the world epidemiology of Kawasaki disease, considering different ethnic groups with different genetic contributions, the hygiene hypothesis, and then wind patterns to explain environmental triggers. And that's quite incredible because that study was only based on 80 patients and might explain 80% of the world distribution of Kawasaki disease. So again, we have to look at these types of data as aspirational and with a pinch of salt, but they're interesting. I'm going to hand over to Professor Tullow now.
Thank you, Paul. So in the basis of this, we wanted to look back and see how we were doing in the UK. So we undertook a British Paediatric Surveillance Unit survey, which looked at all the cases reported to us of Kawasaki disease from both the UK and from Ireland. And we took a 2-year period from beginning of 2013 to the beginning of 2015. And we really wanted to find out how the demographics were in the UK and Ireland, what the clinical presentation was, the link between symptoms and presentation, how the acute management was being given in 2013, and what were the typical outcomes and complications at 30 days of the illness. So 553 children were reported to us, and as Paul has said, typically we saw more boys than girls, about 1.5 times as many boys, and we had a wide age range, varying from about 2 months of age right up to 15 years. As you see from the tables on the right, most of the children were less than 5 years old, but about 20%, surprisingly, were more than 5, so it reminds us not to discount Kawasaki disease in the older child. We also saw that most children had complete Kawasaki, and as we'll find out, that is when children have most of the features of Kawasaki, but some of them had incomplete Kawasaki or even atypical, where they only had some of the features, or they had coronary artery disease with very few of the features. During our study, 2 children died, and one of these was unrecognized during life. And we had one additional case that actually was outside our time period, but the child was reported to us not known to have Kawasaki disease in life, but was found to have coronary artery disease that was so bad that it killed the child because of Kawasaki. As Paul has already said, the ethnicity was of interest to us. People tend to think of Oriental populations being more typically having Kawasaki disease, and that is of course true in the world, but the UK population of Oriental people is much less. We did, however, see that people who are black or mixed white and black ethnicity had higher representation than you'd expect from the UK population. As with any disease, we tend to see more cases presenting in late winter and early autumn. And so each year of our study, we saw that roughly in January, we had our highest peak of children presenting with Kawasaki disease. And it's no mistake that International Kawasaki Disease Day is within January each year in order that people be more familiar with this condition. You might think that people will be more diagnosing Kawasaki disease and picking up more minor cases, and therefore there would be fewer coronary artery aneurysms. This is neither true with the increasing incidence that we're seeing, nor is it true in terms of the increased frequency in terms of presentation in winter and autumn months. We had cases presented all over the UK and Ireland with pretty well similar presentation rates. And this was very important to us. It shows that we had good buy-in from all our colleagues. I'm very grateful to our colleagues in pediatrics, pediatric cardiology, pediatricians with expertise in cardiology and rheumatologists for presenting cases to us. Needless to say, any surveillance study doesn't have 100% acquisition of cases, but we think this is a pretty good overall representation of what we might see in the UK. Having said that, if you thought that the origin of Kawasaki disease was infectious, you would expect to see more cases in areas of high urbanicity, of high population density. This was not what we found. Surprisingly, we saw many more cases in children arising from rural populations. We had their postcodes as part of the data submission, and we showed that those who have very low urbanicity, i.e. coming from the countryside, were much more likely than you would expect to have Kawasaki disease. These children presented typically to their GP. 4 out of 5 of them were seen at about 2 days into the illness. The median time from GP presentation to admission to hospital was about a day, but you see there's a wide variation, and even from the time of admission to hospital, some children languished in hospital for up to 25 or even 36 days before the diagnosis was made. This is critically important and one of the key points that we want to get across during this webinar. The earlier you can make the diagnosis, the earlier you think of Kawasaki disease, the earlier the child will be treated, and the reduced rate of coronary artery aneurysms. We found overall that those children who were treated at less than 6 days into their illness had a very low rate of coronary artery aneurysm formation, but those that were treated at about 10 days had a much higher rate. And therefore, we are really keen that people will pick up the diagnosis early on. They will think of Kawasaki disease. Nobody's suggesting that every child who turns up with a temperature is going to have Kawasaki disease, but you should think of it. You should take a careful history, and as Paul will go through in later, and actually make sure that you're not missing a case, not missing a chance to treat a child and prevent the life sentence of coronary artery aneurysms. So from our survey, we showed that 47% of infant cases were incomplete. These children did not have all the characteristic features. In fact, those who had the giant coronary artery aneurysms were more likely to perhaps just have a fever, a bit of a rash and cracked lips, and not much else. And in fact, even of those children that were treated, 39% of infants developed coronary artery aneurysms. This is not a rare complication. This is something we often see in children who are presenting some of the worst conditions and the fewest symptoms. Overall, over about a quarter of children will present with some form of heart complication. This might be myocarditis, it might be pericardial effusion, it might be valve regurgitation, but of course the most important one might be coronary artery aneurysms. And we found that if you take all children together, about 19% of treated children in the UK and Ireland survey developed coronary artery aneurysms. We've already shown that it's higher in rural areas. We've shown it's higher in Black and minority ethnic groups. We see it's more common in winter and spring, and we really want people to recognize the condition in order to reduce the risk of cardiac complications. Across the world, we're seeing the incidence of Kawasaki disease rising. It's roughly doubling every 10 years. And this is very important, clearly, in countries like Japan, which has got a much higher incidence. But even in the UK and the US, we're seeing the incidence rise steadily as time goes by. As Paul has already said, we undertook a Freedom of Information request from hospital trusts looking back at admissions coded as Kawasaki disease from 2006 to 2015. Overall, during this time, 4 times as many children were coded as having Kawasaki disease. Again, you might think this is because we're picking up more minor cases, but this is simply not the case. We're finding actually even more cases of coronary artery aneurysms, giant coronary artery aneurysms, or severe myocarditis are presenting. So it's not a case of picking up more minor disease. This is a real increase in incidence of Kawasaki disease. And if anything, the disease is getting worse as time goes by.
Okay, so we've now provided with you with a high-level view of the epidemiology of KD, and now it's trying to get down to the individual case. How do you make the diagnosis? Well, many of you will be aware that there is no diagnostic test for Kawasaki disease, and that diagnosis rests on combinations of clinical criteria. To fulfill the so-called American Heart Association criteria, you need to have 5 out of 6 criteria as a minimum for a full diagnosis traditionally, one of which has to be the presence of fever. This is in contrast to the Japanese criteria, the Japanese Ministry of Health, where fever is not a mandatory criterion, emphasizing that some Japanese patients at least can present with Kawasaki disease with minimal fever. But in the UK, we tend to see patients who definitely do have fever, and therefore you require 4 out of the other 6 criteria to make a complete diagnosis. But it's really important to know that there can be so-called incomplete cases, in other words, Kawasaki disease with dreadful coronary outcomes with many fewer criteria, particularly infants. So we'll go through each of these different criteria. The rash is described as being polymorphous, in other words, taking many forms. So you will see on the screen here the first child who is maintaining confidentiality for us rather nicely, with very red lips, a rash affecting all over the body, including the palms, and you get the impression that there is so-called indurative edema of the palms as well, but no peeling at this early stage. Other children may have a rash that would be in the distribution of eczema, mimicking eczema. Mother might say, oh well, they got this fever and the eczema got worse, but no, that's Kawasaki disease. And another small infant with, again, a rash that could be any one of many viral exanthems, but typically affecting the soles, shown here, and again here. The changes affecting the mouth are initially red strawberry tongue, or initially, in fact, a white strawberry tongue, which can later peel and become red. The so-called lipstick sign, perhaps cracking and peeling of the lips, and painful sore lips, and also bilateral non-purulent conjunctival injection without exudate. And you will notice that in the first picture there's an area of pallor just adjacent to the iris, and that's referred to as limbic sparing, which is rather typical of the conjunctival injection that you get as part of the immune response in Kawasaki disease. Changes in the peripheral extremities are important to know about. The initial phases, puffy hands and feet, sometimes referred to as indurative edema, and peeling is actually a late sign and is the sequelae of healing after you're recovering from your Kawasaki disease. So absence of peeling does not exclude the diagnosis. Cervical lymphadenopathy, or indeed lymphadenopathy elsewhere, is a feature, may often just be one side, but doesn't affect all cases. It's often quoted as being greater than 1.5 centimeters, but as I always point out, who actually begins to measure these things in day-to-day practice? So if you can feel it and it's tender and the mother thinks that it's changed in size, it's present. Don't worry so much about the size. There are other clues, however, changes in the perineum, particularly peeling. In fact, the perineum may be the first sign to peel. And one very early sign that may affect some babies who've received the BCG vaccine is a reactivation of the BCG scar. And the immunology of this phenomenon is quite well worked out with reactivation of T cells within the BCG scar reactivating to the mycobacterial antigens and heat shock proteins being involved in that process. And in Japan, this is a very well known sign, and patients will often make the diagnosis purely based on a fever and reactivation of the BCG scar. It's important to emphasize that echo findings may be largely irrelevant at this stage because you will not have done the echo, and you must not wait for the result of the echo to make the diagnosis. The clinical criteria suffice to make that diagnosis, but if there is an early echo performed, you may see inflammation of coronary arteries with or without true aneurysms at that stage, pericarditis, valvulitis, or even evidence on echocardiography of myocarditis. There are other clues to the clinical diagnosis. Children may be irritable, often regarded as the 7th sign of Kawasaki disease. If you happen to do a lumbar puncture thinking about a broader differential diagnosis of meningitis, you may identify CSF pleocytosis, suggesting that some of the irritability may be due to a sterile meningitis. Diarrhea and abdominal pain, aseptic meningitis, as I've mentioned, other inflammatory sequelae, urethritis, even uveitis, and the curious phenomenon of high drops of the gallbladder shown here on this ultrasound can all be features. Skin peeling, as I've mentioned, can be a late feature, so don't wait on this to make the diagnosis. An absence of skin peeling is never a basis on which to dismiss the possibility of Kawasaki disease. You need to consider the presentation at different age groups, and really the important point is to deeply understand that infants currently in the UK, despite IVIG, in 39% of cases will develop significant coronary artery aneurysms, suggesting that this is a particularly high-risk group that warrants more research into better treatments and sooner diagnosis. These children may have incomplete clinical presentations. For all children, including young children, these features don't all have to be present at once. The mother may mention red eyes that have been and gone by the time you see them, but if they have been mentioned in the history, score it as one of the factors that's been present. So sequential presentation of the signs. Again, older children seem to represent a high-risk group and may have incomplete or atypical symptoms, including vomiting and diarrhea and sore throat. And in the UK, 47% of infant cases are incomplete, emphasising that this is not a rare issue and that the current diagnostic criteria are really lacking in sensitivity for you to make the diagnosis. In terms of investigations, there are really very few investigations that are fancy. These are all routine tests. Clinical features, as I've mentioned, should prompt consideration of C-reactive protein measurement and ESR, both of which will be raised, as will be the white cell count, predominantly neutrophils. Albumin may be low, sodium may be low. Viral titers, ASO titers may be misleading because you may get positivity of ASO titer, but that should not put you off the diagnosis of Kawasaki disease. We recognise that 25 to 40% of children may have some evidence of a past infection. So one great paradigm shift, which used to state that you cannot make the diagnosis of Kawasaki disease if there's evidence of infection, has now got to be adjusted, because we know that some children can have evidence of an infection that incited the Kawasaki response in that host. Platelets may be low early on, but will rise later. So again, do not rely on high platelets to make the diagnosis. There are particularly high-risk groups for cardiac sequelae. I've emphasised to you children under the age of 1, those with fewer clinical features, which may contribute to late diagnosis, those with the severest inflammation, the highest CRP, over 100, very low albumin, very low platelets initially. Perhaps males may be more at risk of coronary artery aneurysms. Late treatment, we know, definitely is a factor. In the BPSU study, the median time to treatment was 6.8 days, and those who had aneurysms were treated slightly later at 10.2 days, so almost certainly there's an effect there. So any infant with prolonged fever, please do consider the diagnosis of Kawasaki disease, even if all the criteria are not present. If there is any doubt about this, you should treat that child as Kawasaki disease, if needs be covering with antibiotics, and do not wait on the echo to make that diagnosis. If you strongly suspect the diagnosis, please do treat and catch up with the echo when you can, because it may not be available in your hospital.
So, of course, an echocardiogram is something which interests all paediatric cardiologists and paediatricians with expertise. It's very important that people don't think of just the coronary artery aneurysms. As we've said, children have a high prevalence of myocarditis. If you look carefully at markers of ventricle function, you will often find them depressed in acute episodes of Kawasaki disease. And the only 2 children I've seen who've not survived with Kawasaki disease both died of pericardial tamponade. They had such significant pericardial effusion that was too severe for them. Valve regurgitation can be severe. You could have acute mitral valve regurgitation, such that the valve has to be replaced very early on. But of course, it's the coronary artery disease that people are most keen to look at. In the short axis view, this is the standard view that people are expecting to see, both the left main coronary artery, perhaps the branching of the left anterior descending, the circumflex, and also the right coronary artery. But this is not the only view. And over the next few slides, I've given some details to help people feel a bit more confident about the other views they could get in a child with Kawasaki disease. It's very important to practice these views, and certainly I don't intend to go through every single view that we've listed here. But you have to remember, you want to look at the left main coronary artery, and the best is, of course, the short axis view at the level of the aortic valve. But you may want to find another view from perhaps the apical four-chamber view, and you can see the left main coronary artery coming out very nicely from the aorta. One of the clues I find very helpful is that it's very easy to see the coronary arteries. As you know from an irritable 1-year-old, it can be rather difficult to get nice views. But if the coronary arteries are bright, they're easy to see, that tells you that they might well be involved. And some people refer to ectasia as some of the early signs before you may go on to get coronary artery aneurysms. And just because your echocardiogram is normal at the first stage, until that child is switched off its inflammation, you can't be confident that there will not be later appearance of coronary artery involvement. So these are the other views that you can take looking at the anterior descending and the circumflex. The commonest site that we see dilatation or an aneurysm is at the junction of the anterior descending and the circumflex coronary artery. It's important when you're doing your measurements that you have a machine that's measuring accurately the measurements to a high degree of accuracy. If you look at this, this is recording 6.94 millimeters or 0.694 centimeters. Something that gives you just 0.2 centimeters or 0.3 centimeters is not accurate enough. And all those who are using the echocardiography machines need to use a package which actually gives you the high definition for the right and left coronary artery measurements. We measure from the internal diameters, the internal edges of the coronary arteries. That's easy, much easier than trying to do the leading edge methodology, which, although it might be anatomically correct, is not something that's standard. It's also important to avoid the very mouth of every vessel. Of course, there's going to be a slight delta formation, and you will have a rather larger measurement. So typically, I'll measure 4 or 5 millimeters into the beyond the origin of each coronary artery in order to get a good, accurate measurement. Another feature that I've seen commonly occurring is that people don't recognize that a very large coronary artery is actually a coronary artery. For example, in this child who has giant coronary artery aneurysm, the Z-score here is plus 22. There's no doubt this is a very large coronary artery. You might not look at this vessel and think it is actually a coronary artery. It can be the same size as the aorta, which can lead to a misled diagnosis. And of course, that might be critically important in terms of managing the acute child. Certainly, when you see giant coronary artery aneurysms, it's a very good way for improving your coronary artery anatomy. Here, for example, there's the posterior descending coronary artery, which is not a vessel that we often see when we're studying children with routine echocardiography. And here's the right coronary artery in that same child with giant coronary artery aneurysms. Similarly, we need to view the right coronary artery. We need to get a nice long length of it, not just the first few millimeters at the short axis at the level of the aortic valve. And I've listed here all the different views that you might see the right coronary artery. One of my favorites is in a 4-chamber view, looking at the level of the atrioventricular groove. You can often see the right coronary artery running all the way along the AV groove. This gives you much nicer pictures that you can see in a short axis, where you only tend to get the first few millimeters. And I encourage those who practice echocardiography to go out and see if they can get a good view in each one of these vessels in that nice settled child. Sometimes you need to have some sedation. I quite like intranasal midazolam, very safe, very effective at keeping the children nice and quiet. If you've got an irritable 2-year-old, it can be very hard to get good pictures, and you really need to be confident that you're seeing a clear view of the coronary arteries and you're making sure that you can manage them appropriately depending on what you see. Here, for example, the child with the right coronary artery very dilated, and you might not recognize this as a coronary artery, and therefore looking carefully, being critical, looking at the flows and seeing where else could it be if you can't find a normal coronary artery. So keep your mind open and look for these vessels in more detail. Sometimes you get rather confusing views. Here, for example, is the aorta. Here's the top of the right atrium, and actually this vessel is the coronary artery. It may not be obvious if you're looking at a completely different view. Here, for example, is a subcostal inverted 4-chamber view, looking at the right coronary artery as it comes around the shoulder of the right ventricle, and you can follow it all the way around to the apex. Posterior descending coronary artery, you're only really going to see it if it's dilated. It's not something we routinely see in practice, but you certainly aren't going to see it if you don't look for it. So I encourage people to look, especially in the atrial long axis, which is often the easiest view from subcostal approach. That gives you clear pictures as you need to. Hopefully you're never going to see this sort of picture. This is a post-mortem specimen where the coronary artery dilation was recognized after life. So this child never had the chance to be treated. And these are the angiograms of a giant coronary artery aneurysm in the right coronary artery, and here in the left main coronary artery. And this can lead to mortality. People think, oh, Kawasaki disease, it just burns out. We don't need to worry about it too much. That's not true. Roughly 3% of children in the UK and elsewhere, if they're untreated, will die because of acute Kawasaki disease. This falls significantly to 0.36% if they're treated. But as Paul says, we haven't managed to improve this over the last 3 decades. We need to work harder to improve the children's outcome from the coronary artery aneurysms. And eventually you end up with a healing process. You see myoepiblastic proliferation in the wall of the coronary artery, and this leads to stenosis in the long term, well beyond the acute thrombotic phase, which typically lasts for 1 or 2 years in children with giant coronary artery aneurysms. You then go on to having the risk of stenosis, which may occur 15 or even 25 years later.
Okay, so many of you will be aware that there is, of course, a differential diagnosis when a young child presents with a fever and a rash, and I just want to point out a couple of pitfalls. Scarlet fever is the commonest diagnosis that's made in children with Kawasaki disease, but there's a simple clue here that can guide you. Scarlet fever does not cause red eyes. Now, there are other streptococcal infections with superantigens that can cause a toxic shock and red eyes, but scarlet fever in its classic form does not cause red eyes, so beware the diagnosis of scarlet fever if there is conjunctival injection. Clearly, there are a number of viruses, including adenovirus, enteroviruses, measles, and many others. Meningitis with the irritability always needs to be considered, and it's quite common if there is doubt for children to receive antibiotics, but you can also give IVIG if there are other features more suggestive of KD. In my practice, the main differential diagnosis, if KD does not resolve, is that of Still's disease, otherwise now these days called systemic juvenile idiopathic arthritis. And of course, we sometimes can get caught out with other forms of vasculitis, such as Takayasu arteritis or polyarteritis nodosa. I've seen one case of an IVIG-resistant KD that turned out to be a non-Hodgkin's lymphoma, and of course that's why that's on the list, but that's a rare event. This is some work done by Rachel McCormack from the Patient Organisation Society, which is the UK, one of the main UK Kawasaki societies, just listing the types of diagnoses that patients had received: virus, scarlet fever, meningitis, tonsillitis, and you can see all the different, flesh-eating disease, etc., etc. So as you can see, many people are diagnosed with all of these things before getting the truth that in fact it was KD. The problem is that can cause diagnostic delay and probably worse outcomes. So we just want to emphasize that in early 1990s, the aneurysm rate in children with KD was over 20% despite IVIG. And in fact, if anything, the most recent BPSU study shows that was even higher. So this is Kawasaki disease's dirty little secret, that in fact IVIG does not reduce coronary artery aneurysms down to 4%, as is often stated in the textbooks. And in fact, for infants under the age of 1, the rate was 39% despite IVIG, leading us to want to do more research on better treatments for KD. So at this point, I want to show some video footage emphasizing how delay in diagnosis and bad coronary artery outcomes can impact in a child's life. So bear with me while I click some buttons, and you can watch this video.
So they went to the GP, and the GP just said, basically, take her up to the hospital, gave us a letter of referral.
To check her, just to
check her over. So we went up to our local Worsley hospital. And even at this point, Kawasaki's wasn't something that anybody was thinking about.
But I knew something was more seriously wrong.
I don't think any of them had really heard of Kawasaki's. And it was only when they decided that they'd send, you and Jasmine went up to Birmingham Children's just for a more detailed heart scan because they got more equipment. And they did the heart scan there, and basically they kept her in.
Yeah, Jasmine had giant aneurysms on her aorta, aneurysms down both arms and the tops of her legs.
Kawasaki's was the root cause of all the issues we'd be having for the 3+ weeks that led up to that day.
By the time I got to the top of the stairs, my world completely changed yet again, because Jasmine's on the floor, her clothes had been cut off her, the paramedic was there, and I literally crawled the last two, like, Jasmine, and the paramedic said to me, because he was paddling her, and no response, and I went, Jasmine, I got on the floor with her, and he said, that's it mum, keep talking, because they were getting a thread.
You were in the chapel, and the intensive care just went quiet, and it was like, you could hear the beeps of machines, but it was quiet. It was probably about 10 o'clock at night, something like that. And literally the doctor, one of the doctors came out, and he said to me, can we have a little word? And he said, basically, we found a heart. So this is on the Sunday night. Late Sunday night. And then she had, basically, the heart transplant was on the early hours of the Monday morning.
5 hours.
5 hours of surgery.
It's disheartening to know that so many, increasing numbers of children are being affected by Kawasaki's disease, and this is going undiagnosed or with late diagnosis, because the aftermath of having Kawasaki's disease for an extended length of time is life-changing and life-threatening. I can't stress how important it is for clinicians to be aware of Kawasaki's disease.
I started going back to school on like a part-time basis, so I think the very first time, I think it was literally 15 minutes for form time, at the start of the day we have like a registration, And actually, so I was on 2 crutches, and actually also stood up and clapped me. I could quite actually. So yeah, so it was like very gradual. So it was like that 15 minutes and that one lesson, and then like 2 lessons, then maybe like a whole morning, and then it was like a whole afternoon, and then I started back full time like the next year. I've been extremely lucky to be here, and I am here, and I've got through everything that's happened, and I guess I'm a kind of better person for it actually. Just appreciate what you have, um, and there's always something that worse that could be happening. So just to be grateful for, I'm still here. I'm doing good. I'm happy.
I think the key thing is that we're extremely lucky, and while this was maybe in some people's eyes a tragic tale, and it could have been very tragic at varying steps in that journey, we've been lucky. I wouldn't want other parents to have to have had the journey that I've had. While it's been the making of us as a family, knowing that there's a way to prevent this is critical. Early diagnosis of Kawasaki's disease is vital.
So, as you've seen, missing the diagnosis can have devastating consequences for a child's life. So, I think the key here is to think of Kawasaki disease, and if you think of it, you'll make the diagnosis. So what are we going to do about all these terrible outcomes despite IVIG? Well, as an interim measure, whilst we await some clinical trials, and I'll talk about that just at the end, we identified pragmatically who we think are the highest risk patients who you may wish to target up front for more aggressive treatment. Clearly, if you're already failing IVIG, you're in trouble. Children under the age of 1, those with the most severe inflammation, C-reactive protein over 100, albumin less than 30, anemia, features of HLH, this unusual complication of hemophagocytic lymphohistiocytosis with falling counts, devastating inflammation, sometimes referred to as DIC if you're on the intensive care unit. Think HLH and think Kawasaki disease. And indeed, if you've already demonstrated to have coronary artery injury and still have ongoing inflammation, then of course you're in trouble and you need more aggressive treatment as a damage limitation exercise. If the answer truly is no to all of those questions, you may consider standard treatment with IVIG and aspirin. If the answer is yes, then you should consider the addition of corticosteroid, either prednisolone or a methylprednisolone equivalent. At any stage, you can revise your treatment and give more treatment, more steroids, a second dose of IVIG, anti-TNF agents, for example, infliximab, or even other immunomodulators, such as IL-1 blockade with anakinra or cyclosporin. And then you should perform at least 3 echocardiograms during the acute and subacute phase, soon as you can to diagnosis, but don't wait on the echo to make that diagnosis. Approximately 2 weeks into the diagnosis, and then it's 6 weeks. And thereafter, the monitoring is determined by the severity of the coronary artery injury. No aneurysms, you can stop the aspirin at 6 weeks. Follow up at 12 months if well, and then eventually discharge. If you have small to medium-sized aneurysms defined by a Z-score of greater than 2.5 but less than 10, without any other complication, then you're committed to lifelong follow-up, lifelong aspirin, and an echo as often as required, but typically 6 to 12 monthly. And then more specialist tests later on to stress the heart and to look at perfusion of the heart. And then if you have giant aneurysms, defined as a Z-score greater than 10, with or without stenosis, again you have lifelong follow-up and should be treated with a combination of antiplatelet agents and anticoagulation. And regular echo monitoring as determined by a pediatric cardiologist with an interest. So as soon as the diagnosis is made, you should give immunoglobulin 2 grams per kilogram is 12 hours and aspirin 10 per kilo 4 times a day. and provide supportive management that may or may not include antibiotics if there's some diagnostic doubt. Cardiologists recommend doing regular ECGs to looking for any problems with ischemia, and as I mentioned to you, at least 3 echocardiograms. As the inflammation resolves, you can then reduce the aspirin dose to an antiplatelet dose, bearing in mind not giving any other non-steroidals at that stage, which will abrogate the antiplatelet effect. And then, of course, always look at your case critically. Resolution of fever is not necessarily resolution of systemic inflammation, and you should be aiming for 0 fever, but also 0 C-reactive protein. There are other treatments that are available in Japan for high-risk cases defined by a Kobayashi score. This was a famous randomized controlled trial which showed that for high-risk patients defined by a Kobayashi score of 5 or more, based on the types of severe inflammatory sequelae I've mentioned, corticosteroids made a massive difference, reducing CAA rates from 23% down to 3%. There's now been a meta-analysis of close to 3,000 patients demonstrating the efficacy of corticosteroids in high-risk patients. So we think it's a no-brainer. You should consider this, but it's used by less than 95% of paediatricians in the UK currently, and therefore there is demand for a clinical trial. And I'm happy to report in the last few days we've received a significant grant from the European Union to conduct the so-called KDCAP trial, and we really need everyone on this call to take part in that study. Watch this space. So there are a number of therapeutic pitfalls. I'll take you through this slide before passing over to Professor Tullow. Delaying treatment is important. Failure to recognise where your standard treatment is not winning, and failure to be aggressive enough. Over-reliance on fever is the sole metric of therapeutic success. Aim for 0 fever and a completely normal CRP. Also, the fallacy that there's no point in treating beyond day 10. That's not true. If there is systemic inflammation, you have to treat irrespective of the date of presentation. And also a reluctance to treat incomplete cases. Remember that many cases, perhaps up to 50% of infants in the UK, will be so-called incomplete and yet be at risk of coronary artery aneurysms. Professor Tullow.
So I just wanted to emphasize what Paul said, that the echocardiogram, it can be very helpful. You know, if you have a child who's got just a few features, then getting an echocardiogram early and showing that the coronary artery is involved clearly means that that child should receive immunoglobulin, aspirin, and probably steroids as well very early on in order to minimize the complications. We've been asked already, what if the coronary arteries are normal? Well, if they're normal at the 6-week check and there's no evidence of coronary artery involvement by that stage and any mild swelling or mild dilatation has settled down, then we would stop the aspirin. I tend to see the child once more, perhaps 3 months after that, and if everything's well, I've answered all the parents' questions, there aren't any other complications because of Kawasaki disease, they can be discharged, and that child needs no ongoing pediatric or cardiology follow-up. We do advise, however, that the GP sees them occasionally, gives them good lifestyle advice, makes sure that they keep themselves slim, they have exercise, they avoid diabetes, and all the risk factors, probably true for any member of the public, and occasionally have their blood pressure checked, perhaps once a year, to make sure that there are any other complications are managed. However, if the coronary arteries are abnormal at 6 weeks, i.e. the Z score is 2.5 or more, then that child needs a lifetime follow-up by cardiologist. As Paul has already said, this child will need aspirin ongoing long-term, and their management will depend on their risk stratification. We're about to submit for publication a lifetime guidance, where hopefully you'll be able to read exactly the best way to manage children in the UK based on the best evidence at the current time. The occurrence rate is typically quoted at 1 in 50. Personally, I think that's a bit higher than it really is. I think what we tend to see is the child, next time it gets a temperature or a cold, it will have a little bit of red eyes or a little bit of peeling or a little bit of reactivation of the Kawasaki disease. This is not usually another whole episode and does not usually need to be treated. And you can be certain that any parent who comes across a child who really does get the full house of all the features, they'll be straight back on your doorstep demanding further treatment. You can get more information from the Society website. As Paula said, Society has been very helpful in increasing awareness for families and for doctors across the UK and Ireland about the management and risks of Kawasaki disease. We've done studies looking at the outcome in adults, and it's recognized that increasing amounts of young adults will have either NSTEMI or STEMI because of previous Kawasaki disease, and even just angiography in adults with chest pain, young adults under the age of 40, may often be due to Kawasaki disease, and this incidence is rising. Those children who do have coronary artery involvement, have coronary artery aneurysms, have a lifetime sentence. They may have risk of sudden death. They may need coronary artery intervention. They may need further investigations, for example, angiography, MRIs, CT scan, as we have already shown. And those with giant coronary artery aneurysms have the highest risk. Probably 2/3 of them will require coronary intervention at some point, and certainly there's a risk of death or heart attacks and exercise limitation in the future, which is why they need very careful follow-up by the cardiologist with a careful management plan and a patient-specific plan, which will be coming out in the near future. This is all highlighted from a patient safety alert sent out by NHS England about 2 years ago. A lot of people never saw this, yet it's sent to every doctor in the country, that because a couple of children who'd had previous coronary artery involvement turned up with chest pain, it was not taken seriously. These children suffered some significant complications. So if you see a child who's got chest pain or evidence of myocardial ischemia with known coronary artery aneurysms, you need to take this very seriously. They need acute intervention very quickly, and this may be thrombolytic intervention as much as coronary artery intervention. We have an adult Kawasaki clinic in Bristol, and we manage these patients in the long term. So there's a seamless transfer to adult care, which is becoming more important across the country. We've talked about the risk factors that need to be managed. We've talked about the investigations that need to be appropriate to them, and advice on lifestyle, looking for risk of diabetes, avoiding smoking, having a healthy diet, and we will be issuing detailed guidance over the next few months. There's still plenty of misinformation, which hopefully we've covered during the time of this talk. The only complication is not just cardiac damage. We showed about 20 years ago that there's significant risk of behavioral abnormalities, and about 1/3 of children will have internalizing symptoms, feeling disconnected from their populace group, and this can be relating to Kawasaki disease. Of course, it's very difficult to tell a typical 2-year-old, are their behaviors normal for a 2-year-old, or is it something relating to Kawasaki disease? In general, those behavior problems in Kawasaki will settle over the next couple of years. Another myth is that Kawasaki disease can't be seen with other disease. For example, streptococcal infections, strep throat. And as Paul already said, this is clearly not the case. We commonly have measles or streptococcal infection or something else being seen a few days before clearly an episode of Kawasaki disease is occurring. So just because you find a virus does not give you an example and a reason for avoiding making the diagnosis of Kawasaki disease. As we've already said, skin peeling is a late finding in Kawasaki disease. If you see it, you've missed the diagnosis. So don't wait for peeling of the fingers. Don't wait for it to occur later on. But it can be helpful if somebody said they had symptoms a while ago, they did have peeling later, could it have been Kawasaki disease? Then that can give us an indication of whether they'd be having an echocardiogram to see whether there's any long-term features. One of the other myths is that all the features need to be present to diagnose Kawasaki disease. Hopefully by now you are feeling confident that you could diagnose Kawasaki with just a couple of features. They may have had a rash that has gone. They may have had a red eyes that disappeared 3 days into the illness. And by the time you're seeing them 4 or 5 days, they may have very few features apart from persistent, ongoing fever. If they have nothing else as the cause 5 days into the illness, there are not many other things that could be causing this apart from Kawasaki disease. Commonly, I hear people say to me, oh, the parent said the doctor said it was too rare. I've never seen a case, so it can't possibly. In fact, that's not true. Kawasaki disease is more common than many cases and many types of meningitis. So look out for it, think of it as a diagnosis, and think that these children may have significant complications. The worst cases we tend to see in children under 1 and over 5, so be aware of the fact that we'll be looking out for it in younger children and older children. Expect to see it, think of Kawasaki disease. And if you can treat it whenever there's acute inflammation. If they're still inflammatory at 10 or 11 days, then they will need treatment. If you've missed it, that's fine. Obviously, if everything is settled down, then it may not be appropriate. And that's where discussion may be appropriate for somebody who's experienced in the management of Kawasaki disease. Here's a quick slide just reminding you of our aims. While you read this, we're going to have a look at some of the questions that are submitted and have a discussion about the best way to manage some of the difficult problems that you put to us over the last few minutes.
So thanks for all your interest. We've had some great questions come in, and I'm gonna choose some of the best ones. If I don't get a chance to read out your question, that's not because it wasn't a great question, but with some. So here's a really important one here. So this is hi from Australia. We had a 3-year-old girl who presented with a history of fever, irritability, rash, and conjunctivitis, who had completely normal bloods, had no temperatures in hospital, but got peeling on day 2 of admission. She remained happy, eating and drinking, and I couldn't bring myself to treat her. She presented 10 days later with fever, CRP of 300, lymph nodes and rash. She was then treated, normal echo. Have you seen this before, or have any comments about the first presentation? The answer is yes, we see this, and this is a classic presentation of Kawasaki disease in its sequential form. And it's difficult to know without seeing the case, but it emphasizes that if there is a fever, remember that the treatment does not require you necessarily to have an elevated C-reactive protein. And often the interpretation of the blood tests, whenever I hear about normal blood tests, that makes my ears prick up and I want to see the numbers. But nonetheless, taken at face value, yes, the blood test can be normal, and this is Kawasaki disease and evolution. Another great question, can I ask about the dose of steroids used for high-risk cases? Well, in the KD-CAP trial, you can give oral prednisolone at 2 milligrams per kilogram once a day. So it's very simple. It doesn't require even intravenous access. If the child cannot tolerate oral medicines, you can give intravenous methylprednisolone, either at a prednisolone dose equivalent, so that would be whatever number you multiply by 0.8, so that would be 1.6 milligrams per kilogram, usually as a split dose for 5 days. And then you watch the CRP. There's a question about the half-life of the CRP. The half-life of CRP when there is no production is 18 hours. So unless you are achieving a halving of your CRP every day or so, then there's still ongoing CRP production, and you can use that as a rough guide. Some pediatric rheumatologists will advise even more aggressive corticosteroids with pulses of methylpred to between 10 and 30 milligrams per kilogram for 3 consecutive days, followed by oral prednisolone. And no trial has examined the difference between the doses. The key is to recognize the case early and add corticosteroids. There's a great question here, given the current concerns around availability of IVIG and how often we give steroids for other indications, would it now be appropriate to consider steroids early in the course? Well, yes. And I'd urge you after this presentation to go into PubMed, put my name into PubMed, and find a paper that's just been published called the Share Guidance on the Acute Management, and that will guide you through all of our views on corticosteroids. But we still need you to be willing to enroll your patients into a clinical trial, because we've never done that for unselected cases. Maybe we will be causing too much harm. I doubt it, but that's what the KD-CAP trial will ask about. Rob, any questions that jump out at you?
Yes, there's a question I quite like here, which is, in terms of incomplete presentation in infants, how many symptoms should we be looking for before considering Kawasaki? Brackets, in view of the fact that fever and rash is a very common presentation. I think this is a really good question, and some of the conundrums that the doctors, especially in the emergency medical departments, are facing on a daily basis. Of course, it's common for an infant to have a fever and a rash, and you know that any GP who sees a child who's just a couple of months old with a high fever and unknown cause will be sending that into the emergency department to be seen by a paediatrician. However, it's really uncommon for a child to still have the fever 5 days into the illness. If he had meningitis, still 5 days later, he'd be very sick, he'd be very unwell. If he had a streptococcal infection, then he would have responded to the antibiotics that he was given 2 or 3 days into the illness. That would typically settle down in a couple of days. You're not expecting still to see somebody with unexplained fever and a rash, perhaps with no other features. And in fact, the GP teaching is that fever with no other cause in an infant for 5 days, the most common diagnosis is now Kawasaki disease. There's another question I quite like here, where people say, incidence is rising across the world. Is this because recognition is better? This is clearly not the case. If we found that we were just simply picking up more minor cases and therefore having a higher incidence, then we would have a very low rate nowadays of coronary artery aneurysms. We wouldn't be seeing many causes of giant coronary artery aneurysms. We wouldn't be seeing many complications. This is not the case. As the BPSU study showed, we're seeing even more cases of coronary artery aneurysms than we did 30 years ago. So clearly, it's not just a question of picking up more minor cases. There's a real incidence, and this is reproduced all the way across the world. Similarly, somebody's asked, is there a risk of general anesthesia in Kawasaki? Well, of course, if somebody has got poor ventricular function, if they've got coronary artery thrombus, then you need to know, and this child needs to be managed very carefully. If they have to have general anesthetic acutely, then you really would want a pediatric cardiac anaesthetist to manage all their complications and to make sure that you minimize the risk. But it's got to be a higher risk for that individual patient.
There's a great question here. Youngest infant ever reported to have KD. I treated 2 twins who had Kawasaki disease in the first 6 weeks of life, so even very young children can be affected. There's a great question here in relation to, can IVIG be started very early if all the features are present? Absolutely yes. And in fact, there are some data that suggest that if you do that, there may be a need to give retreatment, and that's not because it's to do with some funny thing about the treatment. It's probably those patients who have got all the features early on have got a severe form of the disease and maybe IVIG resistant. We've got a great question about, does the fever have to be continuous for the 4 to 5 days? Of course, people can have paracetamol and a very hectic fever. IL-10 can be produced, and therefore there can be a temperature that drops. So temperatures can be swinging and rather hectic and chaotic. So it doesn't have to strictly speaking, be absolutely continuous. Any other questions? We've got another 30 seconds, I think. I think we've got a question. What do you say in clinic to a family with coronary artery aneurysms with respect to the short and longer term? Rob, what do you say in your day-to-day practice? They've got aneurysms. What do you say to them, to the family?
I think it's hard. It's hard for these families knowing that they then have a life sentence. In practice, those children who've only got small aneurysms and who are just on aspirin, it's a question of being watched carefully in terms of having a good and competent cardiologist or pediatrician with expertise in cardiology following them carefully, making sure they get the appropriate management without scaring them. We have not seen many children with significant complications because of small aneurysms. That's very different with the giant coronary artery aneurysms. These parents need to be significantly warned. They may need psychology input. This is a serious disease, and we need to manage it carefully in the long term. Excellent. So thank you very much for listening. That has been an excellent presentation.
So yes, I'd like to take this opportunity to thank our speakers and to say that our presentation and question and answer session has now concluded. I'd like to thank our speakers Rob and Paul very much for a very clear and informative talk, and for all those who asked very informative and very interesting questions. I'd like to thank you very much. We will take a record of them, and if we can get them answered, we will attempt to, but there is an opportunity to see our speaker Rob at annual conference if you're attending on the 15th of May at a conference session on Kawasaki disease. So if you're coming along, please do try and attend. For those of you who would like to watch the webinar again, we are recording it and it will be made available on the college's campus website in about a week's time. That is available to people who are members and non-members of the college. So if you have colleagues who are not members and who are in other professions, they are more than welcome to access the webinar. If you found this webinar useful, we have a range of other different webinars available on the campus website from previous live sessions. So please do use the second link on your screens to access those. And we'd also find it useful if you could please provide feedback on today's webinar through the top link available on your screens. That's it for today, and thank you very much for joining us, and we hope you enjoy the rest of your afternoon.